Welcome to Fertility Village. This is your weekly live talk show where community and support come together. With rotating hosts, expert guests, and meaningful conversations, we're here to guide you through the highs and the lows of infertility. Whether you're searching for answers, seeking advice, or just looking for a special place to belong, Fertility Village is your space to connect, learn, and grow. Because it really does take a village, and we are here for you every step of the way. Thanks for joining. Good evening, everybody. Welcome to Fertility Village Live. It is July 23rd, 2025. We're so excited to be here tonight. And we are diving into a topic that we know so many people in our community have questions about, fertility myths. So we are myth busting. I don't know if anybody remembers that show from like back in the day, like Mythbusters. Anyways, that's what we're doing tonight. We're going to be talking about everything from pineapple cores to supplements, old wives' tales, all of it. And there's a lot of conflicting advice out there, and it can sometimes be overwhelming. So how do you know what's actually true and what might be giving false hope or unnecessary pressure? We have a special guest with us tonight to help us sort through fact from fiction. We are so excited to welcome Dr. Kaajal Abrol from TRIO Fertility. Welcome. Thanks for being here.
Thanks for having me, Erin.
Yeah, Dr. Abrol is a reproductive endocrinologist and has supported countless patients through their, well, maybe you could count them, but many patients through their fertility journeys. She's passionate about evidence-based care and compassionate support. So we are so excited to have you. You have a podcast too, don't you?
I do. It's called Fertility Doc Talk, and
love it.
Season 1 came out last year. Season 2 should be coming out this year. And it's really meant like what you're doing, educate and provide reliable, credible information to support people.
That is so exciting. And there's, I think, so much room in the sandbox for all of the fertility podcasts, for all of the information, like wherever people can find information. I think it's so important. So we'll definitely super link those in the show notes so that people can find you and find the podcast, and then they can follow along and jump in where season 2 starts as well. Tell us a little bit about yourself first. How did you get into fertility medicine? And we'd love to hear about you.
Oh, thank you. I thought I was going to be a pediatrician when I entered medical school, and I really liked working with kids. But I was exposed to the world of obstetrics and gynecology and really thought this is what I want to do. I love women's health. I love the variety of the space in the area, and I really thought I'd like to deliver babies. And while I loved that, when I learned about the fertility space and reproductive care and all the hormones and the hormone pathways, I realized this is what I really wanted to do. I think it is a very special and privileged place to be, to really help people start their family, grow their family, and care for people in a very intimate way. So kind of just ended up here, but love it.
Yeah, forget delivering babies. We're going to make them from scratch. I love that. Okay, well, another thing that you told me earlier, which I think is super cool. She did a TED Talk this year. Where can we find the TED Talk? Is it on YouTube?
So unfortunately not yet, but hopefully soon.
Okay.
I did a TED Talk with U of T in January, and we're hoping in the next few months it will be released. So if you follow me on Instagram, you will eventually get to access that. And I think it was a really
amazing
experience.
Very, very cool. It's like on my bucket list to do a TED Talk someday. So we're just going to put the juju out there for that. Okay, so we are going to dive into the myths. We have 10 myths today that we're going to get through on this episode. We have lots of time. It's just me hosting tonight with Dr. Abrol. We're going to get into all the things. But before we do, tell us, what are some of the most common myths that you hear from patients?
Yeah, I knew you were going to ask this, and I'll say maybe my top 3 that come to mind. That age doesn't matter that much. Still be out there, and I think maybe on the heels of that, or the reason for that, is a lot of people think, well, we've got fertility treatment and IVF can solve it all, sort of overcome everything. And IVF is great and it's amazing, but I'm not sure we can say that it can overcome everything, and in particular age completely.
Mhm.
And I would also say one common myth, and maybe it's because, this month I've heard it a lot. People don't seem to always understand or realize that lifestyle factors are super important. And the particular one I'm thinking about is use of marijuana.
Hmm.
I'm still shocked on a weekly basis at how many people use marijuana because they don't necessarily think it's impacting their fertility. So I would say
Interesting.
those feel like my top three right now.
Wow. And I wonder if it's just because of like lack of education. Like it wasn't legal when we were going through sex ed through school and our generation, like I'm talking about my generation who's childbearing age. I'm kind of getting out of that now. But like when we went through school, it wasn't legal. So, there's no education about like how does this impact your fertility. So that's wow, that's so interesting. Okay.
And I think a lot of people are using marijuana, for example, for other health concerns, helping with their
Right.
anxiety,
Yeah.
helping with their sleep. So you assume if it's good for your health or helping your health
Yes.
issues, then
Yes.
it's not necessarily having a negative impact on your fertility.
Right.
And that's where I think.
Yes. I even know somebody who used it for their endometriosis pain because their pain was so severe and it was the only thing that would help with the pain from the endometriosis. And so it was like, that's, this is the solution, but like, is that going to, what's worse?
Yeah. Yeah.
Wow. So
Absolutely.
interesting. Okay, good. Well, we already crushed one myth there. Does cannabis, I don't know if I can't remember the list because I made this a few weeks ago, but that's okay. We're going to get into all the myths. Okay, so let's start. Myth number one. The myth is that IVF depletes your ovarian reserve. So does IVF use up all your eggs?
Okay, so I love this one. In fact, it's actually a common question from partners versus and male partners in particular versus patients. So it is a good question to sort of address. And I think in order to understand why it's a myth, you need to understand sort of what's happening in a natural cycle versus an IVF. So in your natural cycle, all your immature eggs are sitting deep in your ovary. And at the beginning of your cycle, a group of those eggs, immature, come to the surface of the ovary. And they sit in little sacs of fluid called follicles. And so in a natural cycle, FSH comes from your brain, acts on your ovary, and matures one of those eggs. So one of those eggs matures and eventually ovulates. The rest of the eggs that have come to the surface of the ovary are going to die off. You're going to lose them. You're not going to use them. What IVF is doing, or egg freezing if you choose to do that, is taking advantage of those immature eggs that have come to the surface of the ovary. And we're using FSH hormone in the form of fertility medications to mature a number of eggs. So not just the one that naturally matures. And then we can take those eggs out of the body and use them however we want. So we're not using up your eggs faster and thus putting you into menopause faster or using up all of your eggs. We are using eggs that would otherwise go to waste, die off. So I think it's really important to understand that. People don't realize that, you're not just losing that one egg a month that you ovulate, you're losing a whole group.
Yes. I love this answer because I always thought, like, because I did 2 rounds of IVF, like, oh, I'm going to have perimenopause younger. I'm going to have all these, like, and I'm going to piggyback off that question with something that just came to my mind. But the impact of synthetic hormones on perimenopause and, like, do those stay in your body? Like, does that impact, like, future hormones and how things, I mean, maybe we don't have the research yet. I don't know. This is a question that I have because I'm going through all the things now in my 40s. And I'm like, maybe it's because of all of the hormones I took during IVF.
No. So that's my short answer. My short answer is no. But when you take those hormones, those synthetic hormones that we're giving, those FSH and LH medications you're injecting for IVF to mature the eggs, they have a short half-life. They're not staying in your system long-term. So they're not staying in your system weeks or months, and for sure not years. Shouldn't affect your hormones later. You go through menopause when your body goes through menopause, when you were meant to go through menopause. But it's not necessarily going to change as a function of going through a couple of IVF cycles or a couple of rounds of fertility medications for whatever treatment you undergo. So one shouldn't really affect the other.
Okay. Wow. Amazing. We're only done myth 1, and I already feel better about my future and about my own things that I'm going through. So that is great.
Good.
Okay. Let's move on to myth number 2. So fresh transfers are always more successful than frozen. So are fresh embryos better than frozen ones?
Okay, I really do love this too. And I'm going to say the pendulum swings, meaning at one point in time, we were doing a lot of fresh transfers. And then the pendulum swung, and you hear all this stuff about frozen embryo transfers, and everyone should do frozen embryo transfers. And that's all we should do. And there are clinics that only do that. I really think we need to understand that we need to individualize care. There is a role for fresh embryo transfer, and there's a role for frozen embryo transfer. Let me talk about examples. Imagine you're coming through an IVF cycle and your lining just for whatever reason is very thin. Well, then in that case, fresh embryo transfer is not the one for you. Freeze the embryos, fix the lining, thicken the lining, deal with the lining, optimize it, and then put an embryo in. Or if you are doing PGT genetic testing on your embryos, fresh embryo transfer isn't even an option. We're going to biopsy the embryos, we're going to freeze the embryos, we're going to do the genetic testing on the embryos. Or the most important example that sort of comes to my mind is somebody has ovarian hyperstimulation syndrome, mild, moderate, severe, but they're stimulated, their estrogen is super high. It's not an ideal environment to put an embryo in. So in that case, actually fresh embryo transfer isn't ideal. However, on the flip side, somebody who isn't hyperstimulated, who maybe only got a few eggs and has one embryo or two embryos, it may be more ideal to put it in. Maybe the embryo is growing and dividing, but not quite at the quality that we would freeze and it would survive a thaw. Well, in that case, fresh embryo transfer is ideal for that patient. So I really think it comes down to both have a role, and it really depends on the individual patient and their situation to decide what makes sense for that patient and what's going to optimize their chances based on their scenario.
That's great. And I think like individualized care is so important to the, like obviously to the patient. And I think for the like a doctor to just be able to say like, well, this is your situation, so this is what we're going to do, makes somebody feel so much better and like they're in control of their care as well. I think I remember when I was going through it, this was in 2020, so that was my last round of IVF, but it was like, there's a 51% chance of a frozen is better than fresh or whatever. Like it was so close that it was like, really doesn't matter. It's like, yeah, again, like you said, like personalized, based on your own journey. So
I actually tell my patients my fresh and frozen transfer rate is so similar, like you're explaining, like very similar, off by a couple of percent. And I think it's because that's exactly what I'm doing. I'm individualizing it to the patient and their situation to decide who needs a fresh transfer and who would a frozen be better for. And then let's not treat everybody the same. Let's treat them for who they are.
Yes. Okay. Well, if you're listening out there and you're like fresh or frozen, listen to your doctor. That is the answer to this question. That's great. Totally. Okay. Myth number 3, PGT testing, or I think, you can help us with those, the PGT piece. PGT is only for rare cases, not for everyone. So the question is genetic testing during IVF only necessary for people with known genetic issues?
Great. PGT, pre-implantation genetic testing. So we're doing some type of genetic testing on the embryo before we transfer it into a uterus. Now, I like to be totally simple and easy about it. Think about PGT as being of 2 key types. So there's PGTM, which is sort of what you are talking about. There is a known genetic issue, and it needs to be a single gene disorder. So a known genetic issue in a family or an individual that's caused by a single gene. So in PGT testing, we're able to make a probe that then screens for that genetic issue in the embryos so that we're not transferring embryos that are affected with that genetic issue. On the flip side, so yes, we can do that. And I would argue it's not so common that we're doing that, but yes, if a person, an individual has a single gene disorder in their family or in themselves, then we can screen the embryos for it. The other type of PGT is where we're not screening for an individual genetic issue, but what we're doing is screening the embryos for the number of chromosomes. So chromosomes, they hold the genetic material for the body, and in an embryo, you should have 46XX or XY. And so we're able to take those embryos and say, which of these embryos have the normal number of chromosomes? That's called a euploid embryo, versus the embryos that have an abnormal number of chromosomes. They're called an aneuploid embryo. And then we essentially transfer back the euploid embryos and don't use the aneuploid, because aneuploid embryos have a higher chance of failed implantation, a higher chance of a miscarriage, or a higher chance of a baby with a chromosomal abnormality. So the short answer is no, it's not only for people with known genetic issues. It can also be used in individuals who want to screen the embryos to know that they're chromosomally normal. I think the really important part of this is to understand that even though we do this, it's not a guarantee that it's going to necessarily implant, but the idea is to increase the chance of implantation and decrease the chance of miscarriage. And there's a lot of scenarios where you may choose to do PGT. So I sort of talk to my patients about, there's sort of 3 key scenarios I think about for PGT. So we know that with advanced age in people with ovaries, so as the ovaries age, the risk of aneuploidy or abnormal number of chromosomes in the eggs and thus in the embryos increases. So you'll see different numbers, but in general, sort of above the age of 36, 37, it's considered to be advantageous to do PGT to screen. The other place is people who have recurrent pregnancy loss. So a large number of early pregnancies are due to chromosomal abnormalities, not necessarily something you're passing on, but something that just happens. And so the idea is to screen in people with recurrent pregnancy loss to try and decrease the risk of a subsequent miscarriage. And then I talk about doing PGT in patients who have sort of unexplained infertility, to try and look for answers, right? So if I have a young person who's maybe done an IVF cycle and we've put in a number of untested embryos, they're not pregnant, like I'm really at a loss of what's happening. If they were ever to do a subsequent cycle, I would, be of the recommendation to consider PGT, because you want to gather more information, using it more as a test, not just as a treatment option. And then, of course, there is the group of patients who right off the get-go want to do PGT. I have a lot of young patients who have really good egg reserve. We know they're likely going to make a lot of eggs and get a lot of embryos. And while that sounds great, we also know that not all of the embryos are going to be genetically normal. So they want to do PGT to try and minimize their time to pregnancy, decrease their risk of miscarriage. Help me, out of my 8 embryos, help me know which of these are actually genetically healthy and normal that are going to give me the best chance of pregnancy fastest. So I would say that's a sort of other group of patients that might consider this. But
that was my reasoning.
And it makes sense, right?
My first round, I had 2 embryos and they weren't tested, and so we transferred one and it failed, and that was so devastating to me because I had come so far and I was like ready for it to work. And then I was like, round 2, testing. I only want to put in known genetically tested embryos. Now, I think like over the last few years, there's been some more controversy around genetic testing, and like we hear about this sometimes in our support groups, and like the controversy around mosaics and transferring mosaics, the controversy around genetic testing, and like, is that one cell actually enough? So are you comfortable speaking to maybe some of the controversy, or I mean, that in itself is a myth, or myth or not a myth, or there's some confusion maybe in the fertility community?
I would say it's not a myth, right? Like, these are real questions. You could put 10 doctors in a room and you're going to get a different opinion. So, right? Like, that's why I say there are some sort of more obvious reasons to do PGT, but then there's also do I want to do PGT just because I want to optimize my chances? There is a school of thought, though, that with PGT, maybe it's not so accurate sometimes. So am I going to not use some embryos that could have been good? Or when we get mosaic, are we sort of tossing away or not using embryos that could self-correct? Listen, I think that this is an evolving field and technology is always changing. And so I do think physicians as patients, you assume some of this risk and have to understand it and be comfortable with it. But I definitely think there's a role for PGT. I'm not a big everybody must do PGT, but like I said, there's sort of 3 more obvious reasons to do it. But if I have young patients with really good reserve, the unfortunate part is if you don't do PGT and they make 7 or 8 embryos, sometimes it takes a couple of embryos to get to success. That is also very time consuming, but also hard on patients emotionally. So the advantage to PGT is tell me how to optimize my chances in a smaller amount of time. And yeah, fair enough. There is a little bit of risk in that, if you have a mosaic and you don't use it, or if the PGT, you fall into that small percentage where it may not be accurate, you may not be using the embryo. But again, in life, we weigh risks and benefits and we decide where we're willing to go. And I think that's where patients need to understand these risks and then decide where their comfort lies for themselves. Everybody's different. Also your experience, right? You, for example, did an untested cycle, had that experience, and then said, no, I want to do this. I have that a lot with my patients too. And I think that that's not a bad direction to go in, you wouldn't have been in that position if that it worked in the first cycle, but every cycle is an experience and teaches you and teaches your doctor stuff about you. And that's part of the process. IVF is treatment, but it's also learning, right?
Yes. Yeah. There's a lot of trial and error that I don't think people realize when they go into IVF. They just think it's like, well, because a lot of the time a patient comes in, they don't know what this is and they don't know what to expect. And so all of a sudden it's like, oh, this is trial and error. We're just like going to try a protocol and see if it works. And if it doesn't work, we're going to try something else. And so there's a lot of that, I think, in IVF that people don't know about. Okay. We got to keep moving.
I like to call it, I like to call it art. Not so much trial and error. I'm not guessing on my patients. I'm doing this in an educated, well thought out way.
Of course.
So there's a bit of an art to it, but it's not a perfect black and white science. Yeah,
absolutely. Yes, 100%. 100%. As a patient, it could feel like trial and error. Not error. That's not the right. Yeah. You just feel like, okay, this is we're testing the waters because we don't know what's going to happen, right? So we try the most, the method that works the best for most people. And if it doesn't work for you, then we move on to something else or, whatever. Anyways, okay. Myth that we're only on number 4 and we're already 25 minutes in almost. So here we go. we knew this was going to happen. We're like, what if we don't get to all the myths? We're going to get to them, or we're going to have part 2. We'll just see how we go. Okay. So myth number 4, one test tells the whole story for male fertility. So if a semen analysis comes back normal, can male infertility still be a factor? I know the answer already, but I want you to tell everybody.
So the short answer is yes, it can still exist. But let me elaborate a little bit more. So we know sperm is always changing. So sperm has a life cycle of around 80 to 90 days. So I say 3 months. I like an initial semen analysis because I think it's a great screening test to see if there's any obvious male factor. I think the really important thing to understand, it's a look at the sperm at one point in time. And yes, if it's normal, it's reassuring, but it doesn't mean you should never look at the sperm again because things can change. And just because it looked good today, you still have to say to yourself, what has it been doing the last 6 months that you've been trying? And is it going to change in the future? So I think if you are trying at home on your own, you do a semen analysis, let's just say with your family doctor, with your fertility doctor, and it's normal, that's fine. Continue trying or continue doing whatever you're doing. But if you're not pregnant in the next 3 to 4 months, it may be advisable or recommended to look at the sperm again. On the flip side, if I see a semen analysis and it's abnormal, I also don't make rash judgments. I always like a second semen analysis because sperm's a bit finicky, right? So things like not sleeping or feeling sick or just having a bad day can really affect sperm. And so I think it's important to take more than one look. It's also important to know that if your sperm test semen analysis is totally normal, yes, it's only a look at one point in time. It also isn't a test for fertilization. So we look at certain parameters. We look at the count. We look at the motility or the movement. We look at the morphology, which is the size and shape. And these are a good reflection of sperm quality and potential for pregnancy. but there are only 3 parameters. So I think it's important to understand that that sperm can change. And so there are other tests that we can do. There's something called a DNA fragmentation test. It's a different look at the sperm's DNA to see if it's fragmented or broken into pieces. And that can be sort of really give us further information. And I've had cases where the semen analysis is totally normal. And then the DNA fragmentation comes back elevated. So there is merit to getting more information.
Right. And with DNA fragmentation, from what I understand, there's like basically no way you'll get pregnant naturally or with IUI if there's a high defragmentation.
So we say that with a high DNA fragmentation, that fertilization rates can be lower and that you may need IVF, or there are ways to improve it, changing lifestyle, taking some antioxidants. So it's important to sort of explore all of that.
Yeah.
Erin, I have a small issue whereby the battery of my laptop is going to die. I'm just going to take a moment and plug it in.
Sure. Take a minute. I'm going to talk about the journal because this is a great opportunity for me to tell our audience and everybody listening about the amazing journal that we launched a couple weeks ago at the end of June, about a month ago now, and the Oasis Fertility Companion Journal. It is an amazing resource, and it is free for anybody right now on our website. You just have to pay for shipping. So if you go to oasisfsn.com to the end, go to our shop, you'll find the pre-order. It says the journal pre-order. And you'll also, if you go to our YouTube channel or Spotify, 2 episodes ago on Fertility Village Live, we did a whole episode on the journal and what's in it and what it includes and how you can use it on your fertility journal. But basically, it's a fertility companion journal, and it's going to help you in so many ways you don't even know yet. It's going to talk about emotional and mental health resources. It gives you a ton of pages for just journaling and writing down all your thoughts and feelings while you're on this journey. There are rage pages in there so that you can let your rage out. There are WTF appointment note pages. There are questions for your doctor. There are helpful resources, tracking pages, cycle tracking, medical tracking, money tracking, all kinds of amazing resources in the journal. So if you want your free copy, available right now until September 1st, and then there'll be a charge online to purchase it. The only way you'll be able to get it for free after September 1st is to attend an Oasis support group. Either in person or virtually. So you're going to want to go online and get your free copy now while it's free. And then, we'll be able to connect you in. So get online, oasisfsn.com. How was that? Are we good, Dr. Abrol?
We are ready to go.
Okay. Commercial over. Now back to the fertility myth episode. Woohoo! I'm so glad you said something because that would have been awful just to lose you and then have me trying to answer all the myths by myself.
I would never do that to
you. Okay.
I would never
that was great. I feel like we wrapped the male fertility, so that's perfect. So let's go on to myth number 5, which is the myth that every person going through this journey hates to hear this, that you just need to relax to get pregnant. Go on vacation. So I think apart from the stigma attached to people in your life giving you this unsolicited advice, I think the actual question is it true that stress alone can prevent pregnancy? And so speak to stress and speak to people relaxing.
Yeah, can we stop telling people that? Like, nobody can relax on demand, number 1. No. Number 2, I think it's like a really short-sighted way to give anybody advice or reassurance.
Yeah.
Here's my feeling. I tell my patients all the time, partners ask me this all the time, just really concerned about their partners. And it's, is stress causing their infertility and what can we do to help? And here's my feeling. I think stress is really difficult to study. Nobody has any good studies on it because it's hard to sort of dissect it out and say, this is all stress or this is some stress. But I do tell my patients, I think stress probably plays a role. So not the sole role, but a role. And I also feel like you're probably stressed from baseline life. And unfortunately, the fertility journey adds a different layer of stress, and it can take long. the journey of trying to conceive. So I talk a lot about finding ways to manage your stress right when you first come to see me. And it's different for different people. Is it a support group? Is it going for therapy? Is it finding a group of girlfriends or friends that you can totally trust? Is it watching Netflix? Is it reading? Is it exercising? You got to find your thing and really learn to manage or find ways to cope, because it's only going to help you and not hurt you. But I would never sit and say to a patient, stress is the sole cause of your infertility. I think there would be very extreme cases where we would say that, when someone's very ill and, has some sort of major illness, maybe, but not, it's not the norm, and it's not what advice I would be giving patients or medical.
And I think that's like one of the things that makes folks who are going through this infertility journey that weren't expecting to go through this, that had no known cause before, started to try, that makes you feel the most crazy is like people get pregnant all the time. People get pregnant who don't even have access to clean water. They get pregnant. They have healthy babies. Like, why is it so hard for some people? This doesn't make any sense. And it can't just be stress, because imagine those people that don't have access to clean water, what they live in, and that, what they live through, and they still get pregnant. Like, come on, this is crazy. And it makes you feel insane sometimes, like that, this is so difficult for some people compared to others.
Yeah. So people need to stop saying they went on vacation and got pregnant, and they need to stop telling people you just need to relax and it'll happen. Yes, like, this 100%. Is nobody needs that advice.
Yeah. 100%. My naturopath, who was amazing, she used to have this course about like how to make a baby without the crazy. And she'd be like, do the thing that makes you feel the least crazy, that things that you can control. And I love that so much, because I was like, those are the things that help me de-stress and like not stress, like control the things you can control. That actually is a good, like, another little plug for the journal. We have this whole page of like, make the lists of what you can control, what you can't control. It's going to help you to visualize it. We have a worry jar in the journal too. So you can like put all your worries in there and then set a time every day when you decide you're going to worry about them. Who's going to be there with you when you open that jar? Worry about the worries and then leave them over there in the jar until you can come back to it another day. Yeah. That's so good.
Amazing. I like that.
Mm-hmm. Yeah. Isn't that cute? I know. Okay, good. I'm glad that was your answer to that one, because I 1000% agree. Okay, this is a good one. Number 6 myth is coffee kills fertility. I mean, I don't know, because I love my coffee, but do I really need to cut out caffeine if I'm trying to conceive? And this could go for like folks who are just starting to try, or who are, in the midst of an IVF cycle. Like, what is the research? Give us the facts.
Yeah, I do have some patients saying to me, "Oh, I've stopped drinking all coffee," and I'm like, "Oh, you don't have to." So this is what I tell my patients.
Thank
God. Yeah, you don't. And I'm talking about all caffeine. So in whatever form you happen to consume it, pop, tea, coffee, all of it has caffeine. So I tell my patients, the Society of Obstetricians and Gynecologists of Canada, they say under 300 milligrams of caffeine per day once pregnant. The American College of Obstetricians and Gynecologists, a little bit more strict, and they say under 200 milligrams of caffeine per day in pregnancy. If you look at the studies on caffeine in fertility, so before pregnancy, the majority of the studies will say there is no negative impact if you're having less than 200 milligrams of caffeine per day. So that's the cutoff I use for my patients. I say keep it under 150 to 200. I don't talk about number of cups, because I also say it really depends on where you're getting your coffee and how much caffeine. Like Tim Hortons, not the same as Starbucks. Yes. We also talk about that, because I have varying mug sizes on my office desk. So it really matters. So I say go home, look up where you're drinking your coffee from, look up how much caffeine is there, and then decide. But you just want everything in moderation, 1 to 2 small cups per day. Okay in pregnancy, okay while trying to get pregnant. You don't have to eliminate all the things that bring you joy, make you happy, keep you sane.
Yes. Yeah. I love that. And I mean, we spoke to the cannabis piece. Can we talk about wine real quick?
Sure. Wine?
Yeah. Like, is
alcohol.
there any, Yeah, alcohol. I mean,
Okay, let's talk about
yes.
alcohol.
Let's
That's a
talk
really
about
good
alcohol.
one.
We did the cannabis. We're into the caffeine. Let's go alcohol. We might as well.
So alcohol, like cannabis, is a toxin to some degree, but everything again in moderation. So again, the journey's long. Like I'm not telling everybody never drink wine again. You've started to try to get pregnant. So the studies really say sperm doesn't like excessive alcohol and it doesn't like binge drinking. So I tell my patients no more than 4 drinks in a week, no more than 2 drinks in a sitting, because there's some guys who will only have 4 or 5 drinks, but it's all on Saturday night. So you really
Right.
want to have less and you want to spread it out. So 1 to 2 drinks max in a sitting, no more than maybe 4, max 5 in a week. And that's where you're at for sperm.
Yeah.
But less is more. Just because I say up to 4 is okay doesn't mean you have to have 4 per week, right? It's
Yeah.
just
Totally.
keep an eye on it. For eggs and ovaries and women, I think it really depends on where you are in the cycle. So I talk about sort of ovulation being our marker of maybe we should limit it after ovulation, middle of the cycle. You've just tried to conceive. We don't know if you're pregnant. The safest thing and the best thing would probably be to limit it then. But, whether or not alcohol has an impact on egg quality, evidence isn't the best for that. So, in terms of just keeping the toxins low, optimizing quality, I think it's better to limit things. So, I also say a couple of alcoholic beverages in a week max in those first 2 weeks of the cycle is probably okay. But again, just sort of limit it. Don't have to totally abstain, but I would just keep it on the lower end.
Yeah. That's so good. And I think it gives people some flexibility to like not feel like, oh, this sucks. Like I can't do anything fun.
Mhm,
And I think
exactly.
too, like, yeah, there's so many other, like, speaking of toxins, there's so many other things we can do to take toxins out of our life, not just in substance, but like in what we clean with and what we wash with and what we do our
Mm,
hair with and like what we paint our nails with. Like, there's so many other ways we can take toxins out that's going to be supportive to our fertility. And there's
agreed.
so many great products out there. I got into this like awesome little gel product that has like all the main 5 things it's free of. Send me a message on Instagram if you want to learn about it. But anyways, it's like it was the most amazing thing while I was going through my journey. I found this like fun new product that I could like paint my nails with and be happy and feel like, okay, I'm doing something to
Yes.
support this fertility journey because I'm like, and it makes me happy, you know? So
Erin, I actually think that's really good because you come to the doctor's office and we say, don't do this and you can't do this and take this away. We don't want to be so limiting. And I mean, again, like I would say limit the alcohol if you're going through your IVF cycle. We know where you're about to extract your eggs, but
yeah.
on the rest of the journey, like we should be able to do other things and enjoy things and not feel like all we're doing is eliminating everything.
Yeah. I would, the couple times I did retrievals, I would always like have my bottle of wine waiting at home. I'm like, the minute those eggs are out of my
Yeah.
body, I'm gonna drink some wine because
Good
I
for
was like,
you.
okay, the
As you
eggs are
should.
gone, and I'm
Yes.
not doing a transfer. They're freezing those little guys, and so I'm just gonna like, I'm gonna relax and wind down. I'm gonna enjoy that, and that was like my little reward for going through that
Yeah.
shitty thing.
Yeah, good for you. You got it. You've got to
Yeah.
find ways to treat yourself as you go
Yes.
through.
Yes.
For sure.
Totally. Okay, myth number 7. We're getting through it. We're doing good, I think. And we kind of spoke to this with the PGT testing, but we really want to get into the embryo grading question here too. So a perfect, and you can speak to that, but a perfect embryo always results in a healthy baby. That is the myth. So does embryo grading or genetic testing, obviously we know it doesn't guarantee a healthy pregnancy, but tell us why and tell us a little bit about embryo grading.
Embryo grading is great, right? The embryologists are looking in the IVF lab under a microscope and grading your embryo. And we do know it correlates with pregnancy rates, but we also know it's not perfect. I've done PGT testing on patients whereby the 2 top embryos that I would have said, hey, this is great, this is going to give us our pregnancy, are the ones that came back abnormal. So just from that alone, we know that embryo grading isn't everything. But if you're not going to test your embryos doing PGT, then it is like sort of the best marker, the best way to choose. We also know PGT testing isn't a guarantee. We
Right.
know that genetically tested euploid embryos can sometimes not implant, or can result in a miscarriage. And I know that is super frustrating, because from a patient's perspective, from the doctor's perspective, you feel like you've controlled everything. We tested these embryos, we're controlling all the genetics. And when it doesn't work, it's super upsetting and frustrating and all the things, right? And you want
it's a bigger fall, right? From hope to like, and that's like you take it harder when that happens.
For sure. And I always say to my patients, there's a lot more to an embryo than just the genetics. Like I like to really just be simple about it. Think of an embryo as sort of two parts: the genetics, which we controlled, and everything else. So I call it the energy of the cell. And we know age can impact that energy, and lifestyle can impact that energy. So, there's other things that can maybe not work in the embryo, or maybe, PGT wasn't perfect and there's a microdeletion and it didn't detect it, or maybe there's an issue with the lining of the uterus. So there are other factors at play.
So many.
And it sucks, but unfortunately, grading amazing or PGT normal is not an absolute guarantee.
Right. So it's not just a beauty contest with the embryo grading. There is some truth to, excuse me, the actual, 5AA, 5B. You know what? I never knew what my embryo grading was. And I kind of took it. I don't know why. I was never told, and I just never asked the question. I was like pretty naive back then. Now I know a lot more. But I kind of counted it as like a positive, because I never went into a transfer being like, oh, it's only a 3BB. And so this isn't probably not going to work. Like when you know that, sometimes that knowledge actually like takes away your hope, because you know that. And so going into it, like, just like, this is an embryo and we're going to hope that it's going to work, and not having that. On the flip side, if it's like a 5AA, you're like, okay, this is like a really, really great graded embryo. It's probably going to work. But then it's a bigger fall from hope if it doesn't work. Right. So I don't know. I was kind of like, the less I know, maybe the better.
Can I tell you that I would say in the last few years, more and more patients want to know their grading, but
they do.
But I would argue a few years ago, even 5 years ago, people weren't aware as much. And I would agree. I feel like knowing the grading can be quite troubling for some patients. And I worry about it, because if they don't hear AA, they automatically think there's not as good hope. And I worry about where their mental state is in that 2 week.
And that can impact like your, like
everything.
Yes, being hopeful is important, right?
I think so. So while I am happy to disclose it, it's patient's information to have, I don't necessarily get into it at the time of transfer, because I don't, to me, if it was a good enough embryo that I'm considering transferring, or if it's a good enough embryo that I biopsied, or if it's a good enough embryo that we froze it in our lab, then I know it's a good quality embryo. It has potential.
Yes, that's right. Oh, I love that. And I think for people listening, like, if you're questioning this, like you don't have to know. I think that's important too. Like, you don't have to know. Maybe you don't want to find out. Maybe it's easier for your mental health to just not know and just like continue forward thinking like, it's an embryo and the doctor wants to transfer it, and so it must be good enough to transfer, So
Absolutely.
Yeah. Okay. Myth number 8. We've got 15 minutes to go. We're doing so good. I feel like we're just cracking along here. Oh, I love this one. So the myth is that hormonal contraception causes long-term infertility. And I hear all the time, oh, I was on birth control for 10 years or 15 or 20 years before we like TTC. Like, did that impact? Is that why I'm infertile? So if you've had an IUD or taken birth control for a long time, will you struggle to conceive?
Yeah, I hear it all the time too. Social media is really big on talking about how the birth control pill causes infertility. And we really need to bust this myth a lot, because the birth control pill, outside of contraception, has some really great benefits: treating pain, treating irregular cycles, helping with acne. I don't think we can downplay that it can do great things. I know the birth control pill doesn't cause infertility. I think the thing that's playing the bigger role in those exact patients you're talking about, I see them in the office too. They went on the birth control pill in their early 20s. They've now been on it for 10 to 15 years. They're in their mid 30s. They're coming to see me and they're having trouble. It wasn't the birth control pill. they are now in their 30s. Fertility declines
Mm-hmm.
with age.
Yeah.
I think it's the age factor that's playing the bigger role than the birth control pill.
Yes. And I mean, what about the fact that the birth control pill, be it does help with pain sometimes, but like maybe it's masking symptoms that if you had have known at a younger age that you had heavy periods, perhaps endometriosis or something like that, PCOS, you could have dealt with that fertility diagnosis at an earlier age to, you know, maybe help preserve some of that fertility. But
Maybe. So from a PCOS point of view, I don't think it would have changed what you do necessarily. From a heavy periods point of view, I don't think it would have changed anything if you have heavy periods and maybe there's no specific cause. From an endometriosis point of view, it's a good question. Would you have done something different? Well, in theory, staying on the birth control pill and keeping the endo quiet and under control is actually treating the endo and preventing it flaring and progressing and spreading and potentially growing endometriomas in your ovaries and potentially causing scar tissue around your tubes. So I would argue it's still protective. It may be masking the issue. I'm not saying it's solving the problem, but I don't know that it's doing harm per se, other than not giving you the answer about the endo right away.
Yeah. Oh, that's good. I really like that. And I think that really speaks to folks that might be questioning, like, especially if you're younger and you're listening to this and you haven't started trying to conceive yet, you know, like, should I stop birth control younger and, you know, figure something else out?
And it's not wrong. You can come off the pill for 6 months, see what your body's doing, and decide. But I'm not sure we can sit here and say that staying on it long term and keeping things quiet, be it heavy periods, pain, endometriosis, PCOS, I don't know that it's necessarily bad. Understanding that when you come off of it, it may reveal gynecologic issues that were there that you didn't quite know about yet.
For sure.
It's the birth control pill that's causing the infertility. It's the aging.
Yes. And I think, like, for me on birth control, I was on autopilot. It's like I didn't have to think about my body. I didn't have to worry about my body. I just knew I took that pill every day. And then it was like, and so for me, I became very detached from my cycle, which I think did me a disservice later when I was trying to conceive, because I didn't know my body. I didn't know what to watch for. I didn't know when I was ovulating. And so I would just encourage you to, like, people listening, or especially if you're younger, like, even though you're on the pill, like, still know your body, still track your cycle, still track your symptoms, and know your body when you're ovulating, so that when you do come off it, you'll notice the differences. You'll notice, you know, there's so much about a woman's body, and everybody is so incredibly different. And I think knowing your body will do you a massive favor down the road when you do get to a point where you want to, like, have a baby, or when you're trying to conceive, or where you're 10 years into infertility or whatever, you know?
Or when you decide to try to get pregnant, you come off of it, start to track right away. Start to learn right from the get-go. Don't wait to see 6 months if you're having trouble to conceive or not. Just start to track all the things right away. I don't disagree with that.
Yeah, that's so good. Okay, we've got a couple more here. So I love this one because it was like TikTok phenomenon. I think last year it went really crazy. But the myth is that drinking cough syrup with a word I cannot pronounce helps thin cervical mucus. And there was this TikTok phenomenon where I forget which influencer started talking about drinking cough. She got drunk cough syrup and she got pregnant. And some claim it works, but it's not widely recommended. So, Dr. Abrol, what do you say about cough syrup?
Well, people were using Mucinex. So Mucinex has guaifenesin in it. And the idea is that it would help thin the cervical mucus, the same way it's thinning the mucus that's causing the cough. And there was some anecdotal stories starting on TikTok that patients reported, or people reported, getting pregnant. But my argument to that would be, well, would they have gotten pregnant without using the cough syrup? We don't really know. I would say there's a lot of good scientific data lacking here to be able to say this is something I would recommend somebody do. Is it possible? I mean, in theory, it makes sense. It might be possible, but I don't think there's any really good. I think someone or a couple of people's anecdotal stories is not enough to say everyone should go out and buy the cough syrup and take the cough syrup.
Yeah. Okay. I think you wrapped it really well. Definitely don't try that.
Yeah, think twice.
Not scientific. Yeah, think twice. Okay, number 10. We're almost at the end. So this is the last myth, and then we're gonna chat a little bit more about a few other things before we wrap up here. So myth number 10: having sex every day increases your chances of getting pregnant. So does timing matter more than frequency? And what is the weight between tries that's recommended? Because I've heard all kinds of things on this too.
I love this because I do have this conversation in my office regularly, at least once or twice a week. And my baseline statement is I think timing and frequency both matter. And I also often say there is such thing as too much sex when it comes to trying to conceive. So I think timing and frequency will come down to how you're tracking. What do I mean by that? If you're using an ovulation predictor kit, peeing on a stick, then you're going to track right before you ovulate. And so we know you pee on a stick, it's positive. We know that that day and the next day are sort of your two best days because you're getting the sperm there right before the egg is released. And the sperm can stay in the cervix for 3 to 5 days. So even if you're off by a few hours or 12 hours, you're going to be fine. If you are using a different method, so you're using your cycle length and then just tracking because you know your fertile window or you have ovulatory symptoms, or you're using an app where you track and they give you the 5 days or the 7 days, that's your fertile window, then my advice is to have intercourse every other day, unless you can feel exactly when you're ovulating, similar to a predictor kit. And the reason I say that is because if you're going to have sex for all 5 to 7 days of that fertile window, then by day 3 or 4, you're not giving enough time for sperm to reaccumulate in the ejaculate. So it's just not going to be as much good moving sperm there. If you do it every other day, and we just finished saying that their sperm will stay in the cervix for 3 to 5 days, then it doesn't matter when you ovulate. If you ovulate in the off chance you ovulate in the in-between day, sperm will still be there. But you're giving yourself the best chance of putting good sperm there every couple of days.
Okay.
I do have patients who come in and they're having sex, so they think more is better, and they're having sex 2 to 3 times a day. I think they're doing themselves a disservice.
Oh my goodness.
I know.
That sounds exhausting.
But they are. From a fertility standpoint, I don't think you're helping yourself. By time 3, 4, there's just not enough time for sperm to reaccumulate. So if you're doing it for recreation and enjoyment, it's okay. But if you're trying to optimize your chances, then I would say every other day during the fertile window or on the day of a positive stick and the next day is going to give you sort of the optimal chances. And that's the way to time it and in terms of frequency.
Okay. Amazing. We busted 10 myths. Thank you. That is amazing.
Amazing.
Now that we've done that, we've busted some big myths. Let's talk about what does work. So we just want to hear from you for a few minutes. What are some of the most effective evidence-based things that somebody can do to support their fertility?
So I think when you first start trying to get pregnant, maybe even a few months before, I think really optimizing lifestyle is key. And we can't downplay that. I always say to my patients, there's a lot you can't control. You can't control your genetics. You can't control whether you're going to have trouble, maybe that if your tubes are blocked or if your egg reserve is low. We can't control that. But you can control what you put in your body and around your body. So I'm a big advocate of the simple stuff. You're right. There's toxins everywhere. You said that earlier. But I say limit alcohol, no smoking, no vaping. It's not a better alternative when it comes to fertility, and no recreational drugs. Marijuana is a big one, but I mean like really all recreational drugs. Cocaine is a big one I hear about as well. So they're all on the table. That for me is key. I think timing and frequency is key. So really getting to know your body and your cycle, and then timing intercourse, be it with an ovulation predictor kit or be it with an app and using your cycle length, but really optimizing your timing and frequency, and then thinking about some supplements. So for people with ovaries and eggs and women, we want to think about at least getting folic acid in. A milligram of folic acid is fine, taking it on its own or as a prenatal. Having some vitamin D, maybe some coenzyme Q10 that potentially could help with egg quality. I don't always prescribe male fertility vitamins, but there are male fertility vitamins out there. They're antioxidants that have been shown to be good for sperm. I don't think it's harmful to start those. Some people want to wait till they've done a sperm test. I think that's totally okay. But if you're keen to sort of optimize things and you're taking a multivitamin anyways, I think it would be helpful, potentially helpful to improve sperm quality. So I'm really big on the lifestyle things. These are things you have control over, optimizing your chances. I have some patients who come in and they're telling me they're having intercourse once a month. It's just not enough. You're not really going to give yourself a good chance of trying. So timing things, having appropriate frequency, optimizing your lifestyle, to me is the perfect starting point.
Yeah.
And then if that's not working and this hasn't happened, I think that's a point at which you've done it all. It's time to see a fertility specialist. And so if you're under the age of 35, we say you can try up to a year and then consider seeing a fertility specialist. If you're 35 and older, because we know age really impacts egg quality and quantity, I would say 6 months of trying, that's sort of the accepted amount, and then consider seeing a fertility specialist. And if there are other things going on where you suspect a problem, or an issue that needs treatment. So, you've done a sperm test with your family doctor and it wasn't perfect a few years ago, or you have irregular cycles, or you're over the age of 40. These are reasons I would see a fertility doctor right away. And the idea is, let's investigate all the other things now: the uterus, the tubes, the ovaries, the sperm, if there is sperm in a partner. And let's make sure all of that stuff is in order. And if it isn't, let's treat what we can treat. And if it's perfect, or if we treated everything, let's talk about treatment options to improve your chances of pregnancy, as opposed to endlessly trying at home when you've done all the things.
Yeah. I love that. That's awesome advice. And I love the lifestyle factor piece, because I just feel like you have nothing to lose. Like nothing to lose by trying to do like the implementing the lifestyle things. And again, it goes back to like controlling the things that you could control, and Absolutely. Even like the things that are potentially impacting sperm quality. Like you might get pregnant, but if there's low sperm quality, then there's a higher chance of miscarriage, or a higher chance of an abnormality, or an unhealthy pregnancy, or something like that. And so I think the lifestyle things is really good. I think it's hard to dial in on exactly what those are all the time for people. So this is such a good episode for those things, because we talked a lot about the things. Okay, I have one last question, and then we're going to wrap it up. But what is one thing you wish more people really understood about fertility?
I mean, I think it is my party line to everybody, because as much as I do think times have changed and people are learning about fertility, I think we have a ways to go. And the one thing I really wish people knew more is that age matters, and it matters so much. Egg quantity and egg quality does start to change in your 30s. And I'm not here to be scary or negative. It's just to understand that age really impacts your chances of pregnancy and your miscarriage rate as you go through your 30s, and that we have ways to optimize chances, to improve chances, more than ever before. And so it's important to be proactive, learn about your fertility at a time that makes sense for you. I see a lot of single women too, who are not in a position to get pregnant now, and they just want to learn. And then they can explore options like, do I freeze my eggs? Do I not freeze my eggs? Do I want to try on my own? Do I not want to try on my own? But I think it's about taking control of your health and your reproductive health. And I think the first step is to understand things change as you enter and go through your 30s.
Yeah. Oh, that's so good. I love that message for everybody. This has been such an empowering and eye-opening conversation. Thank you so much, Kaajal. Thank you for joining us and sharing your expertise with such compassion tonight, and just being such an open book about everything and busting all the myths. Before we close, just let everybody know where they can connect with you, where they can find you on Instagram. And again, we'll link everything in the show notes on Spotify and on YouTube, where these episodes are going to live forever. But just let us know quickly where we can find you.
Absolutely. So you can find me, and the best place to connect with me is on Instagram at Kaajal Abrol MD. And my Fertility Doc Talk podcast is available on all platforms, Spotify, Apple Podcasts, and I'm happy to connect there. I also have a website where you can also reach out to me, which is kaajalabrolmd.com.
Perfect. Amazing. Thanks, everybody in our village here tonight for tuning in. And if tonight's episode resonated with you, please share it with somebody in your life who might need to hear it. You know that you are not broken. You just need the right support. And we are here for you at Oasis. Join a support group. You can find us. You can sign up. The next support group is this Monday, the 28th of July at 7:30 p.m. We have online groups. We have groups all over Ontario currently, where you can join and find people in person to connect with. You will get a free copy of the journal if you attend support group, the one that I talked about earlier, or go to our website until September 1st to get your copy of the journal. Find us at Oasis FSN on Instagram, on Facebook, on YouTube, and you can go find all the old episodes, not old, the past episodes of Fertility Village Live on our YouTube channel as well, or at the Oasis Fertility Podcast. Don't forget, everybody, your story matters, so you're not alone. Welcome to the village, and we will see you all next week here, Wednesday night, 8 p.m. We're doing a talk about BMI, weight loss, and infertility. It's going to be amazing. Can't wait. See y'all next week. Thanks, Kaajal.